Hi, welcome to Conversations in Interventional Cardiology. I'm Andy Goldsweig. I'm the director of the Cardiac Cath Lab at Bay State Medical Center in Springfield, Massachusetts, and an associate editor of SCAI, the Journal of the Society for Cardiovascular Angiography and Interventions. I'm honored to represent SCAI and our editor-in-chief, Dr. Alexandra Lansky. You can find us online at jscai.org, jscai.org, and follow us on X, formerly Twitter, at myjscai, at myjscai. JSCAI is home to all official SCAI documents and to a number of very important papers published every other month. We're here today to discuss an important set of 2 white papers recently published in JSCAI entitled Critical Appraisal of Current Patient Selection and Endpoint Definitions for Decongestion Studies in Acute Decompensated Heart Failure. I'm joined by an esteemed panel of thought leaders and interventional heart failure experts. We have Dr. Philippe Genereux, co-director of the Structural Heart Program at Morristown Medical Center in Morristown, New Jersey, and senior author of the papers we'll be discussing today. Dr. Daniel Burkhoff, director of heart failure, hemodynamics, and mechanical circulatory support research at the Cardiovascular Research Foundation in New York, and an author of the papers we'll be discussing today. And Dr. David Baran, section head for advanced heart failure, transplant, and mechanical circulatory support at the Cleveland Clinic Weston Hospital in Weston, Florida. So, gentlemen, thank you so much for joining us. Really appreciate your being here. I'm going to start with a question for Dr. Genereux. First, congratulations on this important and really comprehensive set of documents. The papers provide information and tools to guide and to standardize interventional heart failure research. I'd like, if you could, just take us through the most important points. And I know you prepared some slides to share. We'd love to see those.
First of all, thank you so much, Andrew, for the opportunity to present our 2 manuscripts. And first, I have to thank the co-author, especially Gabriel George, who did the heavy lifting on this very monumental amount of work. And I have to thank Dan Burkhoff also for his critical comments and editorials. So indeed, we're going to summarize the finding and the presentation of our paper related to acute decompensated heart failure, mainly endpoint. A little historic note on this. So we came up with these 2 papers where we were in the midst of designing a study with a new device to treat acute on chronic heart failure. And we realized that there were a paucity or a lack of definition and consensus on some very important definition for to quantify or qualify improvement in heart failure patients. So we came up with a big review of the literature and then some proposition for endpoint, very similar to ARC initiative and VARC initiative and all the ARC in different fields. And hopefully Heart Failure ARC will use this work to get inspiration for their future version. Here are my disclosure. So this is a 2-part paper indeed, a lot of work. I'm not going to go into the detail of those 2, but just going to highlight the main direction of findings of these 2 paper review and proposal of definition. And I think just as a background, we know that acute on chronic heart failure is bad and is associated with mortality, morbidity. There's the main manifestation of acute decompensated heart failure is mainly congestion. And what we find out is there's a lack of standardization to define congestion, but also response to therapy, what we call decongestion. So we try to summarize the finding actually of the literature, provide a meaningful summary and table of those findings, and came up with some standardized definition that we can eventually use in study and trials. The first part really was to define congestion and potentially identify some risk factor of patient that put patient at high risk for residual congestion. Obviously, when a patient come with heart failure, some people respond to 1 dose of LASIK, it's over. Some other patients are very resistant and have a more rocky course, and we try to identify those patients that may benefit escalation of treatment. And those factors, we classify them in 4 categories. First one is the frequent flyer in heart failure, the patients that have previous clinical course or multiple hospitalization with kidney disease and cardiorenal syndrome. Second is the severity of congestion. Third is diuretic response initially after 24, 48 hours. And fourth is the degree of renal impairment associated with heart failure called cardiorenal syndrome. And this is a central illustration really where we see a patient. It's possible quickly to identify a patient at high risk for acute decompensated heart failure or poor outcomes. So patients that have repeat hospitalization within 2 or 3 hospitalization within the year, patients that have poor response to diuretic as defined on a spot, urinary sodium spot or urine output, patients that have acute and chronic heart failure, renal failure, and people that have very high CVP, high NT-proBNP, et cetera, et cetera. So that's the main focus of the part 1 is to identify risk factor for poor response to treatment. And this is the criteria we came after summarizing the entirety of the literature. Like I said, 4 category: previous course, severity of congestion, direct response, and degree of renal impairment. And you can see the detail of each factor. Again, people that get hospitalized 2 or 3 times a year, patient that came with a very elevated CVP, more than 16, which has been identified in multiple studies as the cutoff. Patient that came with very high NT-proBNP, more than 3,000. And you can see all the rest. So obviously there's some controversy with those cutoff, and I believe we're going to talk about those controversy in the discussion. So spot urine less than 50 minimal for 2 hours after appropriate dose of diuretic. Urine output less than 600 cc over 6 hours. We all can discuss that. There's multiple this difference of opinion about those, but those are the criteria that we summarize and we came up actually to help guide some objective assessment of congestion. The part 2 of the paper was really to kind of propose a definition of what is congestion, but also what do you mean by successful decongestion, optimal decongestion, and decongestion failure. And we propose a 4 class congestion scheme, grading scheme, and we're going to talk about it in a minute. So this is a central illustration where we assess congestion. First, we assess as no congestion, mild, moderate, or severe. Then we assess actually the efficacy of the therapy, whatever diuretic or device, and we divide in 4 groups, whether is satisfactory decongestion, that we subdivide as optimal or significant decongestion, and then unsatisfactory decongestion as moderate residual congestion and severe residual congestion. Then obviously we define what is worsening renal function, and this is, we use pretty straightforward criteria from the KDIGO definition. And then we define treatment failure, and we're going to go see that in more detail in a second. So we had a very detailed proposed grading of congestion, again, to help classify patient category when they came to the ER or on the floor in the intensive care. We go from no congestion to severe congestion. And as you can see, we have summarized subjective self-reported symptom, NYHA class, orthopnea, some physical finding, GVD, edema, ascites, etc. We use some score, the Everest score, which used six criteria. And more objective measurement, which is important, CVP and wedge with the right heart cath assessment, biomarker, NT-proBNP, obviously, hemoglobin for hemodilution, more sophisticated blood volume analysis, and some imaging that could be used, IVC, ultrasound of the IVC, and some more sophisticated analysis, such as the ultrasound of the lungs with B-line and etc. So these are the proposed criteria for the grading of the congestion. I'm not going to go into the detail, but some are pretty straightforward to obtain and easy to obtain in practice. Then we talk about decongestion, because I think in trial it's important, especially small trial, it's important to assess, are we doing a good job? Do we have a quick effect. If you compare medication to device, for example, is one is better to decongest faster or I would say more completely. So this is the criteria we came up. Again, optimal decongestion, significant decongestion, moderate residual congestion, and severe residual congestion. As you can see, we use a lot of the same criteria that we use to quantify congestion. And we just use criteria to say, well, we have improvement of 25% or 50%, et cetera. You can see the cutoff that we use, which are really literally based on prior literature. I'm not going to spend a lot of time. We define worsening renal function. This is used from VARC criteria, which have been intimately involved for the last 10 years. And just quantify the renal function either at baseline or worsening. And this is, I would say, what is most novel for this paper, and that we hope we're going to use in subsequent trial. We just define what is the congestive treatment failure, similar to what we use in VARC for valve, aortic valve or mitral valve, what we call about bioprosthetic valve failure, BVF. This is what we call decongestive treatment failure, maybe DTF. And you can see we divide in 3 stages. First, stage 3, when patient died from heart failure or have a stage 4 or 5 permanent kidney disease, renal function worsening. Stage 2 is severe, but congestive, residual congestion, but reversible. So, for example, if you need to escalate to ECMO support or VAD, if you need to intubate a patient after trying to use some BPAP, or if you have a stage 4 worsening renal function that is transient or resolved within 30 days. And then the stage 1, where it is like a lingering, a prolonged or complicated decongestive treatment where it takes more than 10 days. You need some dialysis or you stage 3 or stage 2. You have moderate or severe residual decongestion. So really try to quantify and qualify successful failure of decongestive therapy. So that's about the main findings or goal of this manuscript. So of these 2-part manuscript, I believe I'm a structural heart interventional cardiologist. I love PCI, I love valve, but I believe the future is in heart failure, especially acute and chronic heart failure. We try to better understand the field. If we want to bring meaningful device to the field, we need to understand how we can impact patient and congestion. So as novel therapy will come to be tested, potentially on the market, we need to refine those criteria and those definitions to be able to assess those devices, those strategy, or those therapy. So thank you again for the kind invitation, and I'm eager to discuss.
Wonderful. Well, wow. Thank you so much for taking us through all of that. It's a real tour de force that you've put together these 2 manuscripts. And really very exquisitely in great detail defined congestion, decongestion, and treatment failure based on a number of different factors, based on symptoms, physical exam, intracardiac pressures, biomarkers, imaging. It's a really comprehensive definition, and I think this is going to be useful certainly for research studies and clinically as well. I want to direct a question to your co-author, Dr. Burkhoff, who's in the bottom left-hand corner of my screen. Dan, thank you for joining. We know objective research requires standardized definitions of terminology like this, and the quantitative definitions are particularly helpful because they're particularly objective, right? Either the numbers are above a threshold or below a threshold. So let me ask you a question. With definitions like these, practically, how do we classify individual patients, or how should we classify individual patients? Should studies collect all of these numerous data points? And then how should they handle discordant data, right? If a patient has orthopnea and has high CBP, but they've got low BNP and normal hemoglobin, should a study collect all those data points, and then what do they do with the discordance?
Yeah, that's a great and very challenging question, of course, especially for clinical trials. So, the indexes of congestion and definitions of successful, unsuccessful decongestion here are very, very comprehensive and include, a very broad range of parameters, as you pointed out. It's reasonable for clinical trials to collect many, maybe not all. For example, many studies of decongestion don't have right heart cath, so you can't measure, those. They may not have a successful, they may not collect spot urines. They may not collect, blood samples at a very frequent high frequency. So it's unlikely that any study will capture all of these. But in any clinical trial, I think that you really want to hone in on the parameters that you think for your whatever device or therapy you're looking at will most accurately characterize the clinical effects of your particular therapy. So, look, in the field of decongestion, it's most easily to identify these patients as inadequate response to diuretic in terms of urine output. That is the thing that will get the patient decongested, is enhancing urine output. So that is in terms of mechanism of action, of course, you want to see that you are that you are getting urine output. Then beyond that, you could start looking at some of the other factors that may help you, further characterize the clinical success of your increase in urine output. You want to see the patients decongesting, meaning some of the physical factors and maybe some more of the objective ones like the NT-proBNP. But it is very challenging, to pin down and to give a universal answer that's going to apply to every single clinical trial. I would say, just as an overriding statement, that this is an emerging field. There are many devices that are under consideration, and in the paper, they really go into a very nice a summary of the different mechanisms of the different studies, the different devices that are being investigated. But we're very early in this game. There are no devices that are yet approved for this. We're all very early. So we also have to consider what endpoints are FDA going to consider for approval. In that regard, they may or may not consider decongestion per se as a success for an approval. They may require some other clinical endpoints, such as reduction in rehospitalizations. So we really need to see what is, how this whole field is going to pan out over the next couple of years as more studies get approved for initiation by the FDA.
Great. Well, it's an exciting time to be in the field, and it's very exciting to watch it grow, really from this seed that is defining the endpoints that future clinical trials will need to target. Let me ask a question for you, Dr. Baran. You've been a research leader for decades in interventional heart failure. These definitions are very comprehensive. How can the field of interventional cardiology implement these proposed patient selection criteria and endpoint definitions? What are the next steps after publication of these papers to really bring this into the real world?
Well, thank you so much, Andrew. It's an excellent, and also challenging question. It in many ways, it reminds me and it parallels with what happened with the shock criteria that actually Dr. Burkhoff was on our panel and we designed. We thought this was a good idea because we had lots of patients who had shock, and there was very many different grades of shock, and people would all lump them together. So I really commend Dr. Genereux and his colleagues, because this is just a really beautiful set of papers, really teases out the differences. But to get to your answer of your question, it really depends on the community realizing we have a problem, and then also being willing to take a set of definitions. There's nothing perfect or magic about any set. These are very carefully thought of, I really admire that, one could look at that set of papers, which has an extensive literature review. So it explains where we were and some rationale of why these definitions were picked. I think, though, to actually make it a standard, it's going to come on either FDA to say, yes, we'll accept this, this, or this, and then companies will use it, or people will take data sets of trials that have already been done or pilots and apply these definitions and say, look, just like with SCAI, you apply them and this actually works. And it probably will. It's very logical and thoughtful of how they define these. It will help in the future if HFARC or another group takes an adaptation of this. But somebody has to plant the first flag on the moon, and clearly Dr. Genereux and his team have done that in a very insightful way. So I think that the field needs this. Whether or not devices are immediately approved, they still have to be studied. And so this framework is really, really valuable because people need to have a common way of deciding what success looks like.
I think, David, I thank you for your kind words and your comments. I have to say that historically speaking, heart failure trials have been conducted with drugs versus drugs, thousands of patients, where, yes, you can use that and rehospitalization and have a meaningful trial, right? As we start to involve devices, especially in early feasibility, where you have 15 patients, you can't use that. You can use rehospitalization. Obviously, it would be great if no patient can get rehospitalized at 30 days, but you need some mechanistic, surrogate endpoint or mechanistic findings that will prove that, I think that's going to work eventually. So I think that this is where we did this review in the spirit of building future study of small number of patients, hundreds, 300s, where you may not change mortality because heart failure is very high mortality anyway, but you may, decongest faster, decongest better. And I think that was the attempt. And like you mentioned, the goal was really to plant the first seed to say, hey, guys, this is their best shot. We reviewed the literature for you. This is where we came. And, if you think you have better an adaptation of this, please go ahead. But yeah, that's what's conduct for really device and or small sample size studies.
Yeah, it's a very versatile definition. I think, as Dan was saying, you're probably not going to have every study use every bit of every endpoint. Instead, based on the mechanism of devices or therapies that are being studied, you'll pick a set of endpoints. And as you said, given small sample sizes, you'll be able to pick, a bunch of endpoints and say, look, our device in these 10 patients yields improvement in the following 8 parameters. Isn't that amazing? And that's enough to kind of push forward. However, it's versatile enough. I think you can also apply these endpoints to very large studies. You can use the same endpoints in your phase 1, phase 2, and phase 3 studies, thanks to the comprehensive definition. Let me kind of throw out to the group, there are devices that are being generated, being conceptualized every day. How do we get people to use these endpoints and to do so universally so that we all speak the same language in the field?
I can start. Just as a point of fact, the Heart Failure Collaboratory has convened a panel to discuss clinical trial designs in acute decompensated heart failure. I would say that there was a lot of controversy, of course, when you get 100 experts together. One of the advantages of writing a paper with a small number of authors is you can come to consensus very quickly. With 100 authors, it becomes more difficult. So the publications will take time to come out as it goes around and around. I think that these definitions to get into use, I think it's going to take a while for the community, for the heart failure research community, the device manufacturers, to kind of get behind one or another group of the components of these both definitions of diuretic resistance, congestion, and success, because every study will come with its own set of experts to design their study. They will they will have their own opinions about what should be the primary endpoint. I think it becomes much easier in the pilot studies, as Philippe was kind of implying, because in the pilot studies, you want to measure as much as you can, and you're looking at mechanisms and not clinical outcomes. So the pilot studies are really not going to be where the challenge is. The challenge will be in the pivotal studies and how the different investigators that are behind on the steering committees advise the sponsors of what to use. Congestion score, is a primary endpoint of many of the drug trials, like the Everest trial, for example. So that is a clinical endpoint that just relies on congestion. That is based on the fact that we know that when patients are congested, they do have worse outcomes and repeat hospitalization. So it's kind of a surrogate endpoint for a clinical outcome. But nevertheless, in the end, it may be required to show some clinical outcome.
Yeah, I would say also, though, indeed, we can't underestimate the importance of regulatory bodies, whether they be in Europe first or the US FDA. But these devices are going to serve patients who are sick, so things will evolve. I think this set of papers will stand as a really important goalpost of the first steps, and probably largely in some ways be adopted once another step is laid down.
Excellent.
Yeah. To me, again, if you have a patient who's not having a sufficient urine output in response to a significant diuretic, and you could show with your therapy, and this has been shown with several of the devices that are noted in the paper, if you could show that they increase urine output from 100 cc's an hour to 200 cc's an hour, that already is a major accomplishment. And then all the other stuff, should come as supporting evidence. But let's keep it simple. These patients are not urinating enough, and we want them to urinate. So let's keep that in mind.
So I think, I agree with both Dan and David comments. I think that it's always take time to endorse criteria. When we look at the VAR criteria, for example, it took time. And the reality is when you design trial, you use the criteria and they get used. And the fields just start, like Dan said, we're just starting this field as comparing eventually device versus medical therapy. I think this is where those criteria will be useful. In the pivotal, we're going to validate this. We're going to explore where we're good or not, and which one would be meaningful to show a significant difference. So I think maybe in 5 years, my hope is in 5 years, when we're going to first design a study of, okay, let's try a device, whatever the device is compared to aggressive medical therapy. I think we're going to have to use as mechanistic. We're going to need to use SWAN, urine output, sodium. When you think, I'm not a heart failure expert, I try to be, but when everybody talk about the sodium, the spot sodium or the urinary sodium, we're going to start to collect that. So we'll see at the end of the day I believe it's going to maybe get modified, but like David said, it's the first shot. I know we're going to use it at least in one study that we design, but we'll see if the rest of the field will follow. That will be interesting.
Wonderful. Well, we look forward to seeing the definitions in action. Thank you so much, Dr. Genereux, Dr. Burkhoff, Dr. Baran. We're thrilled to include this important paper in the September 2023 issue of JSCAI and to share this fantastic discussion with the panel. Please follow JSCAI. Submit your own work to JSCAI. JSCAI is the official journal of SCAI, the Society for Cardiovascular Angiography and Interventions. See us online at jscai.org, JSCAI.org, and follow us on X, that was Twitter, at myjsci, at myjscai. Thank you all very much.